It was low grade, mostly around 99 to 100. There was no diurnal variation. It was not associated with chills. He used to get fever almost every day. He also complained of generalized weakness, weight loss, and he used to get fatigue easily. He also started having complaints of nausea for past 15 days, which was accompanied by vomiting occasionally. The vomitus mostly contained food particles and there was no hematemesis. Patient also developed dry cough around 7 days ago. It was not associated with expectoration and there was no history of any hemopsis. For his complaints, he then showed to a local practitioner where he was detected to have raised blood pressure. BP at that time was around 160/100. He was then started on antihypertensive medication and was advised some blood investigations, which revealed raised serum creatinine. At that time, his creatinine was 2.2. He was then referred to nephrology OPD at Max Vaishali, where he was advised further investigations. He then presented on the very next day to the ER of Max Vaishali with complaints of reduced urine output. He was admitted in ward. On evaluation, he was detected to have further rise in serum creatinine, and he was along with decrease in urine output. So, in view of reduced urine output and advanced azotemia, an IJV catheter was inserted, and he was initiated on hemodialysis.
What was the creatinine next day?
So, here creatinine has rose to at that time 9.6.
Okay.
Then on the very next day, a kidney biopsy was done and he was managed accordingly. He was discharged on oral steroids and was advised to remain on maintenance hemodialysis. There is no history of shortness of breath, orthopnea or PND. There is no history of swelling over legs, eyes or anywhere over the body. There is no history of preceding sore throat, skin infection, ear discharge, redness or blurring of eye. No history of redness of face, no photosensitivity, rashes, oral or digit ulceration. No history of hematuria, nocturia, polyuria. No history of dysuria or flank pain. No history of loose stools or pain abdomen. No history of any bluish discoloration of finger and toes. No history of any joint pain or swelling. Coming to the past medical history, patient has hypothyroidism for past 3 years and he was on tablet levothyroxine, Thyronorm 75 microgram once daily, and there is no previous history of diabetes, hypertension or any other chronic illness. Personal history, patient is a non-smoker, takes alcohol only socially, had normal bladder and bowel habits before the illness. So
yeah, you can summarize it.
So summarize, we have a 65-year-old male presented with complaints of fever on and off for past 1 month, associated with nausea and vomiting for past 15 days. This dry cough for past 7 days, along with reduced urine output for 1 day. On evaluation, he was detected to have renal dysfunction, which continued to worsen. He was initiated on hemodialysis and a native kidney biopsy was done.
I think we can start from one side. You can stand if you want in between. How do you analyze the case?
So this would be likely a case of rapid progressive renal failure as patient serum creatinine was 2.2.
But he says the history is of 1 month. He says he is having low-grade fever for last 1 month. Body aches, nausea, vomiting, he says, for last 15 days. How do you correlate? It is 1 month later, he says, the patient developed drop in urine output, and that is the time he got the kidney function test done, when the creatinine was 2.2 milligram. So historically, what are you bringing here? You know the case is RPRF, don't bring it that way. How do you analyze? He is the patient who is coming with fever, Baba, 1 month fever. He is having nausea, vomiting, weakness, fatigue. He is complaining of those symptoms.
Maybe progressive chronic kidney disease also, sir. Patient may have underlined some renal issues earlier, and that's why he has progressive renal, likely acute.
His presentation as per him is with fever.
So maybe, sir, some vasculitic events.
It can be anything. It can be tuberculosis in a person. He is having 1 month. In your OPD, somebody is coming. He says, Baba, I have got 1 month history of fever. I have got poor appetite. I have got nausea. You will not think of RPRF first. He is not presenting to you with that. Retrospectively, you can correlate anything. But prospectively, when he is coming to you with a normal fever. Low-grade fever, you said 99 to 100, he was having every day, some nausea, some gradually vomiting. It is later on, after 1 month, he has started developing edema feet. Is that?
So there was no history of any swelling?
No history of any
There was a
swelling.
history of cough for 1 week, and at that time he presented to a local practitioner who, when evaluated, were found to have raised blood pressure, and at that time his creatinine was 2.2.
So till that point, his creatinine is 2.2. He may be a case of CKD. He may be a known case of CKD who has just presented to you with a history of fever, nausea, vomiting, and he also says history of cough. He may be a simple case of tuberculosis. Right? So don't jump to a direct, whatever you know in the exam, don't jump to that diagnosis. Keep your mind open and think what can be the possibility. It can be any collagen vascular disease. Suppose a person has got lupus or any collagen vascular disease, he can present to you with a long-standing fever, low-grade fever. He can come to you with nausea, weakness, malaise in the body. It can be any collagen vascular disease. All right. Yeah. You come to him. Now he says he has got creatinine 2.2. After how many days his creatinine has increased?
So within 1 week, Within 1 week,
the creatinine has gone to.
When he next presented, he presented in the ER with decrease in urine output.
So from 2.2 now he has presented after a week with 9.5. What do you rate now? You can keep sitting. You can answer while sitting only. So now he has presented with rapid rise of creatinine, isn't it? Yes, now whatever diagnosis you were suggesting, now you can label it. But what is RPRF?
Renal dysfunction within 1 week to 3 months.
Any improvement? What is AKI? You can give the definition of AKI.
According to study, serum creatinine greater than 0.3 milligram per day within 48 hours or greater than.
All right. So you are saying a rise in creatinine by 0.3 milligram over a period of 48 hours, you classify as at AKI. He's used the word RPRF. What do you understand by the term RPRF? You can put your mobiles on silent. Yeah. What does it mean? He said AKI is a rise in creatinine by 0.3 milligram in 48 hours. Or the old definitions are also there, a drop in kidney functions by 50% over a period of 1 week. What is RPRF? By definition. You can give the definition of CKD.
Loss of kidney function within 3 months.
So you're saying structural or functional abnormality in kidney functions of minimum 3 months duration, isn't it? So he classified AKI, you classified CKD. Now what is your definition of RPRF?
So rapidly progressing creatinine over a period of weeks to
over a period of days to weeks. So restricted. When you talk of AKI, you talk of hours to days. When you talk of CKD, you talk of months. Here you are talking of days to weeks. So rapid rise of renal function from days to weeks, because he has given you history that it was 2.2, he presents with 9.5, and he also said the history of drop in urine output of 1 day or something. So that is giving you a suggestion that now if a person is presenting to you with RP, this what you call is rapidly progressive renal failure, what can be the possibility, what can be the cause of RPRF?
So anti-GBM disease, good pasture syndrome, and immune complex mediated rapidly progressive glomerulonephritis, and dual positive.
So if I may interrupt,
Please.
is RPGN the same as RPRF?
So don't confuse. So what?
So always try to keep a broader definition and divide according to that rather than jumping to the most common. I understand that most commonly it will be RPGN.
So RPGN is one cause of RPRF. Whatever you're saying, good pasture or whatever. So that is one. Other causes. So she said only one cause.
TMA is
Can be.
So vascular glomerular tubular interstitial and obstructive, sir.
Bring that.
So then vascular TMA, sir, glomerular, mainly RPGN, and it can be divided into 5 other causes, 5 types, sir. In type 1 it is mainly anti-GBM, type 2 is immune complex, type 3 is smaller vasculitis, and type 4 is an amalgam of 1 and 3. Answer 5.
So that is one, she has said rapidly progressive.
Answer is EIN, sir. That will cause answer obstructive, sir. Obstructive.
Anything else? Commonly you also see. You also see multiple myeloma. Don't forget that also. All the collagen vascular diseases, even if it is SLE or other collagen vascular diseases, they can also present like that. So RPRF is a broad term in which RP, rapidly progressive GN, is one entity. You can have, like rightly said, tubulointerstitial compartment. It can be AIN. It can be vascular compartment, TMA. It can be multiple myeloma. It can be collegial vascular diseases. It can be crescents in IgA nephropathy. It can be anything. It's a vast entity. Now, the history is only this much. So where are we? Now you proceed with us that you have only given them this data that patient had rapidly rising creatinine. You have given a data that he has got drop in urine output. What more you want? What information you want from him? You ask whatever, because you have to hit a diagnosis. So what you are saying is, urine examination is part of examination. So whenever in the exam you are presenting a case, you will never present a case without urine examination. So they are keen to know, tell us the urine examination.
So urine routine examination revealed protein 2+, RBCs 15, no cast, and UPCR was 1.32.
I think the rest of the examination also you haven't told right
Urine
now,
exam?
no?
So
No, apart from urine, like
Mainly,
the
I have
physical
not-
examination.
Yes, it's yet to be.
Do you have anything to
I
tell?
have.
Batao.
Please go ahead.
So,
Please go ahead.
over examination.
General physical.
General examination. Height of the patient is 5 feet 10 inches, weight 72 kg. There is pallor. Apart from that, there is no icterus, cyanosis, lymphadenopathy or pedal edema. There is no rash on examination, no evidence of any episcleritis or any nasal deformity. BP was 140 by 90 millimeter mercury, taken in right arm sitting position, and the remainder of the general examination was normal. Coming to systemic examination, there was presence of bilateral fine crepes over bases, and the remainder of the systemic examination was normal.
So you have not given anything positive in the general examination. You have only said that the BP is 140/90, which is also not very bad. You have not said there is any edema or anything.
No edema.
Nothing. So general physical examination is non-contributory. Your systemic examination only you have said find creps in the basis. So some evidence of fluid overload. No pedal edema also.
No pedal edema, sir.
So now that he has told you about the urine. Now with this examination, what have you excluded? Some of the lesions like TMA where the blood pressure is high, you have excluding those features. So now you have coming to what you gather from the urine examination. Yeah, second line. He said the urine is showing protein 2 plus, 15 RBC per high power field. That's it, no cast.
No cast.
Sir, if there is no cast, especially RBC, then it goes in favor of interstitial disease rather than glomerular disease.
Why do you say so? If he is saying the proteinuria is 2 plus, he is giving you 15 RBCs. So anything can occur in clinical medicine. But when you are thinking of those things, you will think more of glomerular etiology here. If a person is having proteinuria, if a person is having hematuria, you think of glomerular etiology, isn't it? Your point. What more investigation you want?
RBC and protein.
Yeah. What is active sediment?
RBC card, WBC card.
The presence of proteinuria and hematuria, there may be WBCs also, that make a sediment active. So possibly this will qualify for an active sediment. If he is having proteinuria and RBCs in the urine. Now what do you want? How you want to proceed further? This is the case which has come to you. He has come to you in the OPD with these all examination. He has given you creatinine, he has given you urine findings. Where are you now?
So we will go further testing because patient having the proteinuria along with RBCs and decreased urine output over the period of within a span of one
Week, yeah.
So we will do serology.
You will give serology. Good. What serology you want?
Sir, most commonly like ANCA, ANA, ANCA, CNCA, PNCA.
You will like to do C ANCA, P ANCA, anything else? It can be a post-streptococcal infection also. It can be crescents or post-streptococcal infection also.
C3, C4.
So you would like to do C3, C4 also. If it is lupus, you will like to do lupus serology also. So these serologies you have asked for. Your reply. The answer their question only.
So his viral markers were negative. C3 170.
How much? You say which one?
C3.
C3 is
170.
normal or abnormal?
Normal, sir.
Normal. Range you can tell them.
Normal is between 90 to 180.
There, whatever labs
Here it's
range.
170.
Okay.
C4 is 25. Normal range is 10 to 40.
So that is
So both
C3,
C3 and
C4
are
is normal. Just a minute. With C3, C4 normal, what have you excluded?
It's unlikely to be post-streptococcal or infection related.
If it is post-streptococcal, what did you expect?
C3 might be low.
C3 should have been low, right? And now this is not there. So that means any C3 glomerulonephritis also is gone. C3, C4 is low. So that means the active lupus is also gone. Otherwise, you would have expected that, isn't it? Coming to you now. Now, give them the answer about other tests.
So ANA was also negative.
ANA is also negative.
Anti-PR3 was also negative. Anti-MPO, that is Pianka, was 2+, and anti-GBM was 3+, and anti-GBM titers were 451.
So now he is giving you that it is P-ANCA was positive and anti-GBM is also positive. So it's a dual positivity is coming. All right. Okay. So where are you placing the diagnosis?
Vasculitis, anti-GBM can be positive.
Yes. So now he has come to you with the ANCA positivity, P-ANCA positive. What is ANCA? You can just tell us ANCA.
Anti-neutrophilic cytoplasmic antibody. So they are usually positive in ANCA-associated vasculitis.
Now, where is the antigen?
So there is TR3 that is in the cytoplasm, and MPO is present. MPO is present in nucleus.
All are cytoplasmic. Keep in mind.
Name
Name is ANCA. ANCA is what? Anti-nuclear. What is this? Anti-neutrophilic cytoplasmic. For nucleus, you are doing ANA. That is the ANA antibodies against the nucleus. Here it is cytoplasm. Cytoplasm has got large number of antigens, almost 700, 800. The important ones, what you are saying is P-ANCA, which is peri-nuclear, MPO, myeloperoxidase. You have got cathepsin, you have got many of these antigens are there. So important one, what you are dealing with, he said P-ANCA. C-ANCA is negative?
Negative, sir.
And anti-GBM. You can comment on anti-GBM. What is the normal range of anti-GBM in your?
So that I did not write. So normal range I don't know.
Not?
Sir, I did not write the normal value.
No, whatever the level was, it was strongly positive?
Strongly positive, sir. I think
Fine.
it was around 80, 90, it's 450.
So it is strongly positive. So so what are we dealing with?
Dual positive glomerulonephritis, which is the ANCA is also positive and anti-glomerular basement membrane antibody is also positive. So it can occur dual positive.
No, it can occur. It can occur in significant, almost 20% patients. So you are managing him as RPGN. Now the question is, how are you going to manage him? Are you going to manage him as P-ANCA associated vasculitis, or you are going to manage him as anti-GBM? You want to maintain. Now, any question first?
No. I'm sorry.
What is the biopsy now? You did the kidney biopsy.
So light microscopy it revealed kidney biopsy in 3 linear cores revealed 22 glomeruli, of which all glomeruli shows crescent, 19 are cellular, 3 are fibrocellular. In addition, 8 glomeruli they show segmental necrotizing lesion, and there is no evidence of any thickening of glomerular capillary wall, no mesangial matrix expansion or mesangial hypercellularity seen. Tubulointerstitial compartment, it shows diffuse acute tubular injury of mild degree. There is moderate interstitial inflammation seen in 26 to 30% of the cortex, sample cortex, and IFTA is around 5 to 10%. Immunofluorescence, IF core reveals 6 glomeruli, IG 3+ linear along the capillary loops, and IgA, IgM, C3 and C1q negative.
Fine. So logically, what he is saying is 22 glomeruli. 22 glomeruli, out of
22,
which
22, sir.
20, the
Two,
majority are
19
having crescents,
Cellular.
cellular crescents. So with this data, what is against P-ANCA? Yeah, go ahead. So logically, he is having a linear pattern of immunofluorescence. So there is no ambiguity that anti-GBM antibody is present. So P-ANCA may be positive. So logically, when you say the dual positivity is there, outcome may be, the relapse rate or outcome may be guarded. But yes, he has got anti-GBM glomerulonephritis. More importantly, when you say that the crescents are of the same level, same stage,
Same age.
right? If you are having all the glomeruli having the same stage, as you said, all are having crescents. 2, 3 are having cellular.
So most are
19
having
cellular.
cellular.
Most of them are
and
having
some
cellular.
fibrocellular.
So majority of them are having cellular crescents. So there are no staging of this. So logically it is going in favor of anti-GBM disease. Now you can correlate the history that the prodrome of the illness was before, that you were having some sort of viral, because when you say anti-GBM disease, there can be any history of fever, there can be any history. Previously people used to say history of hydrocarbon exposure or something. So the history, low-grade fever, the constitutional symptoms were already there. Fortunately, he has presented to you with the cellular crescents majority, right?
Yes, sir.
Would the biopsy findings change your management? You were saying something about how you would. You were talking about like how you will treat like anti-GBM and not like anchor.
Because if the biopsy goes in favor of anti-GBM disease, I will like to treat it as anti-GBM.
नहीं पर क्या करोगे? How will you go ahead? This is the patient now. He's your patient.
Treated aggressive.
Go ahead, go ahead. What you want to give him? Because if he is a anti-GBM antibody disease, logically you are, that's all right. You want to stop production of antibodies, but you have to remove these which are causing the damage. So that is a priority to you. So every alternate day, every day plasma exchange, the limit is some people want to do 7, some people want to do even more, because you will keep doing it till the anti-GBM levels have fallen down. What did you do?
So we started with, patient was given methylprednisolone 500 milligram once daily for 3 days, and Plex was started. On we did 3 days daily, we did Plex, and then the next 4 cycles of Plex were on alternate days. We were doing alternate day dialysis in Plex. So the patient was dialysis dependent as well. So Plex and steroids.
No,
and then
you gave endoxin also
yes, sir. Endoxin was also given 750 milligram.
on day 1.
Yes, sir.
Okay. So you gave endoxin, you gave methylprednisolone pulse, and they gave plasma exchange. That is what you can offer to them. And they carried on, they gave 7 sittings of plasma exchange to him. And what was the outcome?
So upon when the patient was discharged, he was in maintenance dialysis.
He was maintaining?
He was in maintenance hemodialysis. And later on, after I think 1.5 to 2 months, he became dialysis free.
How much the creatinine settled down to?
So last I followed was somewhere around 2.
So that's a fairly good response what you are saying, that the treatment will remain primarily endoxin and steroids plus plasma exchange. So plasma exchange, how are you titrating? Till what level you are giving? You stopped after 7?
So we give for 2 weeks. So we can give
What
up
is the
to
recommendation?
14 days, till the anti-GBM levels become undetectable.
Why do you think you gave plasmapheresis
give
in
up
this
to
patient? What was the reason for giving plasmapheresis?
So anti-GBM, we will.
So do you give plasmapheresis in all anti-GBM cases?
So ma'am, especially if there is alveolar hemorrhage. Patient has presented with.
So did this patient have
Patient is
alveolar hemorrhage?
dialysis dependent. Creatinine
Is there any contraindication to plasmapheresis in anti-GBM disease
No, we give anti-GBM.
in all patients?
In all.
Is that the consensus? Yeah, I think आपने नहीं बोला ना. Do we give in all patients?
For the patients who are already dialysis dependent, it could have been only an anti-GBM disease. If the patient would have been dialysis dependent, there would be very less chance of reversibility in this patient. Because there is a dual positivity, we will still treat him as per we will give him plasmapheresis. But if it would have been only an anti-GBM disease, I would not have given him much if he would, because anti-GBM does not resolve as compared to ANCA.
So not just dialysis dependent, but in addition to more than 80%, between 80 to 100% crescents.
Unless he would have had diffuse alveolar hemorrhage also. That I would have treated.
So in his case, to my understanding, he has ANCA as well, which will respond probably to the plasmapheresis. He may be having alveolar hemorrhage. What was the cause for anemia and this dry cough? Was it worked up?
Ma'am,
Did he have DH?
no, CT, I think CT was done, which was normal. It did not, there were no alveolar infiltrates. There was nothing to suggest alveolar hemorrhage.
Yes, so in such patients, we have to keep that because he wasn't an overt fluid overload. He didn't have decreased urine output, but he still had dry cough. And he was pale, although any chronic illness can present with anemia. So you have to keep that in mind as well. So if he had an alveolar hemorrhage, if he is actively hemorrhaging, then you will definitely do, even if you're not saving the kidney, you have to first save the patient. So you would have done that. But here I think the reason is more that, the ANCA part will be taken care of. If it was anti-GBM alone causing like all the damage, it is unlikely that he would have recovered from dialysis and had a creatinine of 2.2. I think that's what
that's
I
true.
think, sir.
Because he is dialysis dependent. Logically, what you said is outcome you don't expect that bright. Maybe the ANCA also was playing some role. And incidentally, what is the anti-GBM antibodies?
So follow-up titer, I don't know. The repeat titers.
Why do you think you don't know it?
So we need to check.
Your faculty might have probably, I think the treating physician will think in the same way कि मान लो उनका anti-GBM अभी positive भी रहता है. So what else can you do? You've already done plex. There were 100% cellular crescents. Unlikely that you will be able to titrate the plasmapheresis to the anti-GBM levels. But you would rather you gave like a fixed, 6 or 7 cycles, probably because you were treating it more like on lines of ANCA. That's what at least I feel, because if you were doing it for anti-GBM, then you would definitely have repeated the anti-GBM titer, isn't it?
Go ahead.
And what else regarding management, I wanted to ask you, why was again I think that points more towards an ANCA associated vasculitis. Anything else in your treatment regimen which is more like ANCA?
Is also given cyclophosphamide.
Cyclophosphamide you give in anti-GBM as well, right?
If you are managing him as ANCA vasculitis predominantly, what will be the treatment?
So there will be an induction phase and a maintenance phase. Induction will start with IV methylprednisolone. We start with 7 milligram per kg per day. We give it for 3 days, and then we switch to oral prednisolone, 1 milligram per kg per day, which we try to bring it to as low as 5 milligrams OD by 16 weeks. Then we can give cyclophosphamide. Cyclophosphamide, IV cyclophosphamide dose is 15 milligram per kg per dose, and we can also give oral cyclophosphamide, that is 2 milligram per kg per day.
See, when you have this case, you should be saying what you will give to him.
In this patient, we will give pulse methylprednisolone, and
You have given that.
you had given.
Yeah.
and then Plex, and then we can also give
I'm hearing Ritux from somewhere. Do you think
Ritux.
that's
will
the right
be-
answer?
Ritux will be helpful.
Why would you, who said Ritux? Is there any reason why you would choose that above Cyclo over here?
Sir, ma'am, a trial, Peximus trial was.
Say again, what is Peximus trial set?
You dig your own grave.
Peximus trial meant for what?
It was Plex.
That was for plasma
Plex
exchange or
and
low dose
steroids.
steroids. Normal or low dose steroids. Whatever the new guidelines are, the 2024 ANCA vasculitis guidelines, what is new in that?
So a combination of rituximab plus cyclophosphamide 2 and 4 doses, sir. In this case, because it's a severe case, he was dialysis dependent, we could have given, if it was only ANCA vasculitis, we could have given cyclophosphamide or a combination of 2 doses of rituximab and 4 doses of cyclophosphamide, as that was proved by Supplex. Lexivas trial, yes, sir.
Not Peximus.
Ritux was.
Well, there are different concepts. Now, if you look at the Indian Journal of Rheumatology guidelines for India, that is the Indian guidelines which have appeared last year, as per them, they are not too much advocating the combination therapy. KDIGO guidelines do mention that what you said, that if it is a severe disease, the option is you can choose either between rituximab and cyclophosphamide. Generally, the feeling of most of the nephrologists is cyclophosphamide is pretty good in severe disease. So that is how the concept is, that if you are giving rituximab to them in very severe disease, you can think of combining with limited doses, 2 doses of cyclophosphamide. So carry on with the rituximab as it is. You can combine it with 2 doses of cyclophosphamide, or carry on only with the cyclophosphamide. How do you give cyclophosphamide? How much?
15 mg.
But
But in this patient,
change it with renal creatinine clearance. So whatever is required, easier way is, let's say 500 milligram if he is requiring. Carry on with that 500 milligram. How often?
0, 7, every 2 weeks for the first week.
Which one? What are you talking about?
Cyclophosphamide.
Cyclophosphamide. Yeah, so initial 3 or 4 pulses you give every 2 weeks, and then you can make it every 3 weeks. And depending on, some people like to give it for 6 months or 9 months. So you can just tailor the medicine as per the patient.
Above 60 years, we decrease the dose by 2.5 milligram.
Yeah.
Above 70 years,
Another
more
2.5.
So around 10 milligram.
Correct.
Less than 30, less than 30 ml
2.5.
we again decrease it by 0.5.
That's what you said, 30 to 60 reduced by 25%. If it is below 30, you reduce by 50%. That's what I said. The dose will eventually come to 500 milligram. If 15 milligram, 60 kg man, it is working out to 900 milligram. If such a patient comes who is already on dialysis, GFR is less than 10, the dose becomes half of that. So it will be just 500 milligrams you have to give. So that possibly the treating physician would have given, as Dr. Pallavi told you, that they thought, my anti-GBM में तो सारे crescent आ गए. All crescent, patient is dialysis dependent, creatinine is 9, what is the value? The response may not be there. But they gave the benefit of plasma exchange to them, stopped it after 7 exchanges, and keeping in mind some people still prefer to give plasma exchange, though there is no solid data as on now. But in such severe cases, some people like to give for some time. So they have given it. Are you continuing with endoxin or rituximab now?
So that
If you say the response is so good that creatinine became 2 milligram after 2 months, after 2 months we presume you have given 3 or 4 pulses of endoxin. Are you giving?
Last, I don't know. I've not followed up since like 2 months.
So possibly maybe the treating physician has given endoxin pulses and the steroid, whatever. What are the newer guidelines? What are the changes you said? You would like to say? The newer guidelines, what are the changes from old guidelines?
The combination.
That is one. One you said is that. The first, they only conveyed that biopsy is not mandatory. That if clinically you are convinced that he has got P-ANCA positivity or C-ANCA positivity, clinical profile is like this, you can embark on treatment before going for biopsy, and biopsy can wait. That was the first. Second, you said for therapeutic purposes, they said that for severe cases, a combination therapy can be considered. Third, they said,
The rapid tapering of steroids.
yeah, the tapering of steroid, because whatever trial, even Pexivas told you that slow dose is pretty good. The other trial also, Luvas, also told you that. So possibly rapid tapering of steroid is required. And lastly, what was the fresh change? Yeah, that's pretty expensive drug that if available, anybody, you can tell how is Evacopan acting. C5a inhibitor. So where is C5a in this ANCA?
It's posse immune, right? So then how does complement come into the play?
Anyone? And you can all logically when you say the ANCA, so first step is on the neutrophil gets primed. Primed means the cytoplasmic antigens come on the surface. So this is first, neutrophil will get primed. Now second stage will be the antibodies, ANCA antibodies, which are formed against your own autoantibodies. They will combine with them. Once they combine with them, then the alternate pathways gets activated. And that is where the complement comes in. This activation will draw more neutrophils around. So that is where what you are saying is the further chemotaxis and phenomena, you are going to stop it there with Evacopan. So Evacopan, what was the stage 4 said you? Evacopan can be tried in patient with, you said, where the steroids are either contraindicated or you don't want to give any patient who is not wanting the steroids. So those are the people you can give Evacopan. Is it as good, better or worse? Evacopan versus steroids, let's say.
Steroid sparing.
Steroid sparing? Yes.
And the trial has been proved better, sir. In the trials, it has been proved better than glucocorticoids.
The trial only shows that if the trial followed the patient up to 52 weeks. When they went up to 6 months, the response is similar. But when they went up to 1 year, then you find the relapse rate is less in the Evacopan group. The proteinuria regression is more in the Evacopan group. So Evacopan at 1 year is found to be superior than steroid, but at 6 months both are same. That is what Evacopan said. Yeah. So that is 4th or 5th change what you brought. And last change what you are coming out, what Indian guidelines also recommend, that you can give the treatment maintenance should continue for longer period, because the trials also have shown that if you are taking the maintenance therapy 2, 3 to 4 years, logically the relapse rate is much less. So the the last recommendation was this only, that prolong the maintenance phase to longer period. You can stop at 2 years also, but the recommendation now is it is preferable to go over up to 4 years. And finally, you also said that if you are doing maintenance, that possibly, not possibly, the trials have shown rituximab is superior to all others. All the azoran and other things, it's superior to that. One point also, the Indian guidelines differ. They differ that they do not recommend Indian guidelines that you should give oral cyclophosphamide. They believe that because the cumulative dose becomes too much. Possibly the response rate is little better with oral, because oral you are giving 2 milligram per kg body weight. So to a 60 kg man you are giving 120 milligram. So that means in a month you will give him 3.6 gram, 120 milligram a day. In 1 month 3.6 gram. If you take it 6 months, you are giving him almost 21, 22 grams of cyclophosphamide. Whereas if you are giving IV, we said 500 milligram every 2 to 3 weeks, possibly 1 gram a month, you will give 6 grams. So there's a lot of cumulative dose difference. So that is why the Indian guidelines don't recommend that one should opt for oral ones. Agreed, the response rate will be higher if you are giving oral. The relapse rate will be lower. But if you look at the survival in the long run up to 7-8 years, it will be similar. So therefore it will be prudent that you try to give IV make it a policy to give IV cyclophosphamide rather than going to oral cyclophosphamide. Your comments.
So I think, anyways, you have learned a lot about the treatment, but focus a lot on the case also. So if, for example, you had gotten this case after the examination to make a syndromic diagnosis and differential, so what would you have made?
So my first syndromic will be acute kidney disease, AKD, and their RPGN. In that RPGN, acute interstitial nephritis, maybe ATN, myeloma related AKD, and second syndrome will be acute on CKD.
Okay. And like sir said, I think it looks more like an acute on CKD. Probably I would have kept acute on CKD above RPRF or AKD, but that's okay. And in considering he had a history of fever, cough and decreased urine output, like what would your etiological diagnosis of the AKD or RPRF be?
Vasculitis, infection related glomerulonephritis, then IgA, Crescent.
Why IgA? You have overt constitutional symptoms, unlikely that it will be IgA, right? In fact, it could be infection associated IgA, but that you will get only after the biopsy. So that you shouldn't be saying in your possible diagnosis at this stage. Because here, again, you know that it is ANCA and anti-GBM, so all your discussion is going on that. But only if you are able to arrive at the right diagnosis and differentials in your exam will, and not just in your exam, like eventually, like when you're treating patients, will you be able to go to that level, right? So first you have to obviously be able to arrive at that. So I think myeloma also should definitely be, so like you said, there was no overt decrease in urine output initially, and he had like fever, low weight loss, low grade fever. So I think myeloma also could be a very good possibility in that case. And especially at that age, I think we always have to keep that as a possibility.
And first क्या रखना चाहिए मैंने इस वाले इसमें? If we don't know about the ENA and anti-GBM, only on history and examination, what should we have been the first DD?
What do you think?
Between IRGN and vasculitis only.
Between?
IRGN and vasculitis, ma'am.
Yeah, so I think I would probably keep vasculitis. Vasculitis, and then secondly, definitely IRGN can be kept. Nobody can definitively say without a biopsy whether it's going to turn out to be this or that. But considering fever and constitutional symptoms for almost a month. And then you have an RPRF kind of presentation, and you see that urine is showing active sediment. At that age, generally you cannot discount vasculitis at all. But definitely in our population, we cannot forget infections.
So at this age and without
With this age and a male gender,
No, that will be.
I don't think you should keep
We
it.
should not keep that.
Like, you know, if somebody keeps probing you after myeloma also कि नहीं कुछ और बताओ, then maybe at the bottom of the list you can say it, but
I thought it was a female. So.
And for syndromic, we will keep acute on CKD first. And then,
How would we justify CKD?
yeah, because no nocturia, no previous.
how many of your patients actually present with nocturia in your general practice? Because the only thing which I think is like what sir also pointed out, that the creatinine was 2.2 even when he presented, and like within 1 week it has gone up to 9.9. So वो मतलब वो 1 से 2.2 किसी long period में हुआ होगा, and then suddenly probably it has jumped because he was symptomatic for almost a month. So probably if you are keeping, especially if you are keeping infection related gene, then you would probably keep that on. That probably makes more sense, that there was some CKD and on top of that there has been an insult causing.
But we can keep RPRF also. We keep acute on CKD, then we can keep.
Yeah, that's what I'm saying, that you can keep both syndromic diagnosis, but you should be able to justify which one you're keeping and form possible etiologies of each. So I can say that this patient probably had ANCA vasculitis from a long term. You know, he had CGN because of ANCA vasculitis, and then the anti-GBM, you know, caused the acute illness part. So with the drop in urine output. So it depends on how you want to interpret it. Eventually nobody knows how much part was played by which illness in this patient.
So it is more like a renal limited your GBM disease, and with maybe some role, how much role being played by ANCA, we don't know. Nobody knows that. It's very fortunate. I think the patient has responded to your therapy, and that response you are not expecting of anti-GBM disease. That response you are expecting of ANCA. Yeah. So possibly you will have to, if he is responding well, you will have to continue the treatment for a longer period. What you are saying, syndromic or whatever, the possibility will remain when we talk of RPRF, whether it is a vasculitis, whether it is an infection-related glomerulonephritis, whether, as Dr. Saab said, myeloma. Though at age, these are the possibilities first. Lupus will not come. That will be possibly one of the not inclusive. And I think these will be the three. Any questions from your side?
Suppose this patient does not respond to treatment. So since how long we have to treat to say the treatment response?
When you are talking of anti-GBM disease, I think you have to carry on for 3 months. And the recommendation is after 3 months, if there is no response, you can give up the immunotherapy. But if the response is coming like in this patient, you will have to continue the therapy. At times, it becomes very perplexing that you can get some patients. Rarely, anti-GBM also had got pretty varied presentation. We had a case 15 days back only. It came from Cambodia. Some patient came for transplant. So I found that kidneys are normal size, everything is good. So why should he go for transplant? He's not a diabetic. We did a biopsy, and the biopsy, Rajan Duggal reported that it is anti-GBM disease. But anti-GBM disease in various phases. He said some are fibrous crescent, some are fibrocellular, and one odd is cellular. I said, you never hear that in anti-GBM disease. He said, this is my third case I am seeing. He said, rarely these people have the different stages also. That is also a possibility in these cases. But for exam, nothing doing. It is all one stage only. So, but it can occur. And in older people, as mentioned, multiple myeloma must be considered as a possibility. Yeah.
I think considering his question, sir, I think in ANCA there's no guideline exactly when to stop, but by consensus, if the patient remains on dialysis for more than 3 months, people do not continue immunosuppression, because generally a lot of patients of ANCA AAV will become off dialysis. But if you think that the patient is remaining on dialysis, then I personally have lost a patient like that. So I think that somewhere we have to draw a line, because just improvement in urine output doesn't always mean that the patient is going to be off dialysis.
If the response is there, you will carry on. Man, if a person remains dialysis dependent, that means there is no response. It will be prudent. As I said, every case is individual. Then you have to think after 3 months, should I continue? I will stop it after 3 months if a person remains dialysis dependent and I have given him the adequate treatment.
In fact, the patient which I was talking about, I stopped it at 3 months. 2 weeks after that, he had a bad pneumonia. And I was like probably thinking, should I have stopped before those 3 months? But sometimes he was a young patient. Sometimes with a young patient, you always keep thinking, keep trying, but then you have to always balance the infection part.
So the Cambodia patient with a biopsy report having multiple stages, what makes one think that it could be anti-GBM?
It was linear staining. It was linear staining, and he said this is a total linear staining. There is no other option. And anti-GBM antibody, they checked, it was positive. It was positive. It is unfortunate that we could not treat him, because all these agents which bring the patient, they bring the patient for transplant. They are getting their money for transplant. I told them, no, Baba, we will not do transplant, we will treat him. I don't know. After 2 days, the patient disappeared. Possibly they have taken to some other hospital. Because I mean, that is the value of human life. Yeah, it happens sometimes. These biopsies give you. We had a patient recently. He is biopsied in one of the hospitals in Gurgaon. The same lab reports it's lupus nephritis, full house. Logically, the hospital starts treatment. They gave him whatever is the guidelines, MMF or whatever. He comes to us after 4 months. He said, I have for opinion. I said, proteinuria has increased significantly. It became 7-8 grams. So I thought maybe it is converted to membranous class 5. So I said, let's re-biopsy and then we will. We re-biopsied and the report comes as IgA nephropathy. It is from the same lab. I told Rajan Tugal, I said, what is it, Baba? Your lab has given the report that it is lupus nephritis. And after 4 months, we are finding there are only IgA deposits. I mean, then they again went back that it is a MPGN type of pattern. What is it? That patient had MPGN type of pattern that time, which is with treatment has resolved and come to. I mean, they can give you different shocks, the biopsies, but like he possibly would not have thought that it is anti-GBM disease. He gave a total history, no ear discharge, nothing that. He was trying to exclude that we thought only the granulomatous polyangiitis, but these are surprises he got, that it is anti-GBM disease. Yeah. Any other feature you want to convey about vasculitis or any of these crescentic glomerulonephritis? You know the basics, we have not gone to the basic. What is a crescent? I mean, these are the basics. We thought that. Yeah, you can tell us what is crescent? Anyone? You can tell us. When do you say this is crescent?
Infiltration of the cell over the medullary space.
More than 10% of the bone's capsule.
2 or more cellular thickness of epithelial cells. All right? Even if there are 2 layers, 2 or more layers of epithelial cells have to be there to call it a crescent. That what you are saying is whether it's a global or focal crescent or something. How a crescent is formed? Like to tell them?
Resident and immigrant cells, they both proliferate as a result of any insult or progressive etiologies.
So there has to be first a damage in the capillary wall. Unless the neutrophils, macrophages come out of the capillary wall, it is not possible. Because you have to cause proliferation of epithelial cells. For proliferation of epithelial cells, you break the wall first. So once you break the wall, whatever necrotizing vasculitis or endothelial damage occurs, that is the time your cytokines and the cells will come out. And this is the time when they will have chemotaxis, drawing other cells, and these cytokines will cause proliferation of that. And in severe stage, that is the time when the Bowman capsule also will rupture. And then these cells will come out in the interstitium. So you must read the stages, what happens in crescentic glomerulonephritis. The first stage, all the inflammation, antigen-antibody complexes, or whatever, has to be in the bloodstream. Then there has to be a breach in the endothelium. These have to come out. There is a proliferation in the Bowman capsule. And then Bowman capsule also breaks, and then the cells go out in the interstitium. And that is how the progression is occurring. And that is how from the interstitium then the fibroblasts come out. And they start laying the fibrin. And that is how the fibrous crescent is forming. You must read the stages of how the crescent is formed. Anything else you want to teach them about? Anything? Say again? Pseudo crescent. बताइए.
So, first of all, what do you think? Since you asked the question, कुछ तो आपको idea या कुछ पढ़ा होगा.
Crescent is formed of fibrin and epithelial cells and inflammatory cells.
Right. So basically, pseudo crescent is what you generally see most commonly in collapsing GN, where it's just a hypertrophy of the podocytes which will appear like a crescent, but it will not actually be a crescent. So there will not be fibrin deposition nor inflammatory cells in that. So in fact, that is why also very often nowadays they say that it should not be only 2 layers, it should be more than 2 layers, because apart from the visceral and parietal, there should be another layer of cells or fibrin or something in between between the parietal and the visceral epithelial cells. And so mostly it will not be fibrin, and inflammatory cells will not be present there, and it's actually sometimes very difficult to differentiate on pathology.
So you're not having epithelial layers in that pseudo-crescent. As you said, collapsing. The glomerulus has just collapsed, that is giving an impression of crescent.
And you will not have a rupture of the GBM or...
You see the on electron microscopy, the crescent, any crescentic glomerulonephritis, there will be tear in the endothelium from where it will leak out. You can pick up under electron microscopy.
Also, I think you said that 10% thing is there in the definition. That of the circumference should be covered by that, by the crescent, yeah.
That becomes a focal and global they want. That's it.
So actually in the, when we have multiple layers, the multiple layers should be covering more than 10% of the, I think they gave it in one of these definitions recently.
Right.
Yeah. Anti-GBM patient. Does it merit any treatment because he must be on dialysis since he was brought for transplant, he must already be on dialysis.
Achha, that patient. No, the question is, if you find a person on biopsy, there is one cellular crescent, rest are fibrous, or maybe you find 10 crescent, 10 glomeruli, let's say, 7, 8 are fibrous crescent, 2 are fibrocellular, 1 is cellular. The question is, should we treat him? I will treat him. Even if there is some point of activity I am getting, that there is a cellular crescent, the activity is there, I will treat him. Because you don't know, biopsy is just a spectrum of the glomeruli you are seeing. How much glomeruli are active, how much salvage you can do, I will treat. If all of fibers is different, if there are fibrocellular or cellular, I will treat. What will be your point?
So I think if they present with a mixed lesion like your case did, so shouldn't we also keep a possibility that this is anti-GBM plus post-immune non-ANCA vasculitis? So I would probably treat that patient considering that there are multiple ages of crescent, so it's not just anti-GBM but a post-immune vasculitis without ANCA.
Possible, because though of course both P and C were negative in this patient, we don't know if they were there at that point of time, because he was on dialysis for 2.5 months. So at that point, whether there was a combined anti-GBM or this like this patient, like we don't know. So whenever I will find a person is having a single cellular crescent, unless the IFTA is not bad, IFTA is like you said 5 to 10%, I will treat. If a person has got IFTA is 40%, 50%, then you get 1% fibrocellular, I may not. But if I find a cellular crescent, maybe rest are fibrocellular or fibrous, I will treat.
So in fact, even we had a similar patient like this, and she was a young girl, and different ages of crescents, anti-GBM positive and ANCA negative, but like florid different ages of crescents, and we did give her therapy, but she did not respond. But she was, in fact, when she came to us, she was not on dialysis, but she became dialysis dependent very rapidly, and she did not respond to the therapy, but her presentation was like she had some fever and constitutional symptoms also, which were not typical of an anti-GBM. And this different ages again, it prompted us to treat, but unfortunately she did not respond. But since we were going to obviously put her on dialysis long term, and she was keen for a transplant, so we wanted to give her one last chance. Eventually, we in fact rebiopsied her after the treatment, because again there will be some improvement in urine output, but she will not be ever be dialysis dependent. But at that time there was all fibrocellular crescents, and IFTA was very high, so there wasn't any sense in continuing.
Can we close it? I think if the, yeah, any.
So can we have an anti-GBM disease without microscopic hematuria, or is at least microscopic hematuria always a part of anti-GBM?
You're saying there should be.
So anti-GBM disease, is there a possibility of a patient being labeled as anti-GBM disease, but he does not even have microscopic hematuria?
बात बनती तो नहीं है.
So
When you say anti-GBM disease, the antibodies are forming against the glomerular basement membrane. So basement membrane will breach. If he is developing fibrous crescents, there will be some breach. And if the breach is there, RBCs should leak out.
So previously I read in textbook that it was a negative, as you answered, sir. But today I read a book, sir, it was written that rarely it can happen. So I was confused.
Rarely to kuch bhi
I
hota hai,
don't.
but don't
The
say
question
this
is,
in your exam, I think.
during our student days, we were given an impression anti-GBM disease does not exist in India. We all used to see other diseases, pauci-immune, granulomatous, everything. We never saw anti-GBM. It is gradually we have started seeing more and more of anti-GBM. 35 years back, I tell you, 90, we never heard of. We used to think that anti-GBM is in Caucasian population, Western population, not in India. So I don't know. It doesn't appeal that a person has anti-GBM disease and there is no microscopic hematuria. It is something like ANCA, of course. You can have 5 to 10% of people who are still ANCA negative. Yeah. Because if a person is having crescentic glomerulonephritis, the crescent has formed. The crescent will only form if there is a breach in the endothelium. And if the breach is there, the RBCs have to leak out. Unless you start making that there is so much of epithelial crescent that is all choked, nothing can come out. Theoretically that can be a possibility. Otherwise it should be there.
So in a very early stage of disease also, when we have serological evidence, yet crescents are yet to be formed.
It's pretty early that it's not crescent. Then you will not pick up crescentic glomerulonephritis. Then you are getting any endocapillary glomerulonephritis where the RBCs will come. It's like endocapillary glomerulonephritis. Endothelium proliferation is there, breach is there, it is coming out. So that is what you say, the infection-related glomerulonephritis, that is what will happen.
This textbook actually is a grand rounds in nephrology by Dr. Kasi, something like that.
Kasi Visveswar.
Visveswar.
It was line was on that, something like that.
That there is, it can be rarely. Well, maybe. They would have seen one of the writers, I'm also a writer in one of those, that grand round. So one of the writers might have seen a patient that there is no microscopic hematuria. Yeah. In medicine, everything is possible that way. Yeah, please.
So one question. Actually, in this case, both the anti-GBM and ANCA was positive. But we also find cases in which earlier ANCA is positive, RPGN patient, the ANCA or the ANCA is positive, but anti-GBM is negative. But when we repeat the test after some time, then anti-GBM becomes positive.
There is a theoretically fully agreed what you are saying. Theoretically what they say, when the glomerular basement membrane is getting damaged, necrosed, then the glomerular antigens become apparent. And antibodies can form against them. That is the way what you are saying, that initially a person is only having pauci-ANCA. Now, after pauci-ANCA, whatever it is, the glomerular capillary wall is damaged. So once it is damaged, the glomerular basement membrane antigens are exposed. So if the antibodies forms against that, that is how initially it was only pauci, later on anti-GBM antibodies can appear.
Will it change the management course, or we have to rely on biopsy only if we are getting the same?
Logically, it will be p-ANCA or whatever, the pauci-immune, that treatment will go. Because that GBM antibodies, whatever you are saying, you are not having the linear staining and crescents due to that. It is only that you may give a positivity of that. So management logically will go that if you will do biopsy of such patient, logically they will be like ANCA, that with different stages of crescents will be there.
But sir, shouldn't the acute management be more like anti-GBM and like continue on a maintenance therapy, because you know that it's the anchor which is caused.
Yeah, but treatment will remain the same only for.
Like the plasmapheresis.
Plasmapheresis,
it would be more intensive with the plasma probably. But immunosuppression, of course, will be like your anchor, because this patient will obviously have a chance of relapsing later on, so you will have to give them long-term therapy. You can't just treat like an anti-GBM.
Can be, that is another point, that if it has become strongly positive, anti-GBM antibodies are strongly positive, that means that total glomerular basement membrane is exposed and active antibodies are forming against that. If that is the situation, logically, then the plasma exchange will come in. So every case will be individualized. Yeah. So if nothing else, we can back off.